Correction, Hallux valgus, Bunionectomy, with Sesamoidectomy when performed, with resection of proximal phalanx base, when performed, any method. The physician surgically corrects a bunion of the foot using a Keller, McBride, or Mayo type procedure. The physician makes an incision along the medial aspect, inside, of the big toe. The incision is carried deep to the metatarsophalangeal joint. In a Keller procedure, the median eminence and 1/3 of the base of the proximal phalanx are resected. This is followed by repair of the plantar plate and stabilization with a longitudinal K-wire. In a McBride procedure, the adductor tendon and transverse metatarsal ligament are released through an incision made between the first and second toe. Following the release of the contractured lateral structures, the subluxated first MP joint is reduced and the median eminence is excised. The medial capsule of the first MP joint is imbricated through a medial arthrotomy incision. In a Mayo procedure, the first metatarsal head and its articular cartilage are removed and the remaining bone is restructured. Excision of a medial exostosis is performed. The external joint capsule is configured so that it can be used as cartilage between the metatarsal bone and the base of the first proximal phalanx. Fixation devices may hold the bone fragments in position. The wound is closed in layers after thorough irrigation. Correction, Hallux valgus, Bunionectomy, with Sesamoidectomy when performed, with distal metatarsal osteotomy any method. With proximal metatarsal osteotomy, any method. The physician treats a bunion of the foot with an osteotomy, a cut in the first metatarsal bone. The physician makes an incision in the skin over the top of the foot at the base of the big toe. Depending on the particular osteotomy to be performed, the incision may be made over the medial, inside, of the foot, or two separate incisions may be made. The incision is carried deep to the bone. Tissue is dissected and debrided as needed. The bony eminence, or bunion, is removed from the first metatarsal head. The physician cuts through the bone, performing the desired osteotomy. The pieces of bone are realigned to their correct position. Fixation devices may hold the bone fragments in position. The wound is closed in layers after thorough irrigation. Correction, Hallux valgus, Bunionectomy, with Sesamoidectomy when performed, with first metatarsal and medial cuneiform joint arthrodesis, any method. The physician treats a bunion of the foot using a limititis type procedure in which the joint between the first metatarsal bone and first cuneiform bone is fused. The physician makes an incision in the skin between the first and second toes on the top of the foot. The incision is extended deep to the first metatarsophalangeal joint. The physician releases the contracted structures of the lateral joint. A second incision is made in the top of the foot over the first metatarsocuneiform joint. The joint capsule is exposed and opened. The articular cartilage of the joint is removed. The ends of the bones are fashioned so they fit intimately together. The joint and bones of the big toe are manipulated into alignment. Fixation devices are needed to fuse the metatarsal and cuneiform bones. Prior to closing the incisions, the sesamoid bones are examined and removed as needed. The wounds are irrigated and closed in layers. Correction, Hallux valgus, Bunionectomy, with Sesamoidectomy when performed, with proximal phalanx osteotomy, any method. The physician treats a bunion of the foot using a phalanx osteotomy, Aiken procedure. This procedure consists of a removal of a bony wedge from the base for the proximal phalanx. A medial-based wedge is cut, allowing reorientation of bone while leaving the lateral cortex intact. The medial eminence is excised. Fixation is accomplished by crossed K-wires. The wound is closed in layers after irrigation. Correction, Hallux valgus, bunionectomy, with sesamoidectomy when performed, with double osteotomy, any method. The physician makes an incision over the first metatarsal. In a distal Austin double osteotomy, the soft tissue is corrected and a V-osteotomy is made through the metatarsal head and neck that is displaced laterally to replace the metatarsal head over sesamoids. K-wire fixation is used and a cast is applied. Hallux rigidus correction with chelectomy, debridement, and capsular release of the first metatarsophalangeal joint, without implant with implant. The podiatrist makes a dorsal incision over the first metatarsophalangeal joint. The extensor hall UCI's longest tendon is retracted, and the joint capsule is entered. Osteophytes and part of the metatarsal head are excised. Bony irregularities may be removed using a chisel, and edges smoothed with a rasp. When adequate dorsiflexion, 60 to 80 degrees, is obtained, the capsule is closed, the tendon is returned to its correct anatomical position, and the skin is closed with sutures.